of diagnostics for cancer, and the main concept with diagnostics is the early treatment. Using diagnostic for early treatment, sometimes days can make difference for the surgical excision, let's say aggressive colon cancers, and usually treatment should follow diagnosis very rapidly, very promptly. And prognosis is the best if treated early, because remember, if you lose time, you may let the cancer to spread. Exceptions are, again, skin cancers as basal cell carcinoma or squamous cell carcinoma, but those are exception cancers, and small delay in treatment may not be that instrumental, or may not be that significant if we compare it to other type of cancer. Again, when we're talking about skin cancers, we exclude malignant melanoma, which may be very deadly and may require rapid, very prompt treatment. When there is a suspicion, the biopsy is recommended. Sometimes the cancer presentation will be so obvious, so already the patient will be scheduled for removal. In some organs, presence of the tumor or neoplasm, regardless it's malignant or benign, may be having very drastic consequences, and removal will be warranted even without discovering what it is. And most of the time, most of the tumors, regardless malignant or benign, will be removed at some point. Routine screenings may be helpful, and by screenings we, again, breast cancer screenings and colon cancer screening with routine colonoscopies, and we'll talk about the screening guidelines about those diseases when we talk about them in particular. But again, screening can be very helpful. Prostate cancer screening is becoming more and more controversial, and I will talk about it later in the course. General signs and symptoms of cancer. Pain is one of the hallmarks of cancer, unfortunately, and patients with diagnosed cancer, and especially metastasized cancer, may have significant amounts of pain and may require very aggressive pain management and introduction of unusually high for other pain presentations doses of opiates and other pain control medications. So if you work on cancer ward, you probably will agree with me that the medication may be dispensed quite often and in larger doses than, let's say, if you compare it to even such high pain management floors such as orthopedics. Obstruction may occur, and by obstruction we are talking about obstruction of the blood vessels, or obstruction of a duct, or obstruction of the colon. In this case, obstruction may be a relatively good thing, because obstruction may cause symptoms and signs that will lead to further examination and discovery of the tumor. However, obstruction may present with very critical conditions and may be developing quite rapidly, and the obstruction need to be addressed also very quickly. Hemorrhage is another consequence of the cancer, and hemorrhage can be developed secondary to disruption of the vessels and invasion of the cancer, as well as most of the malignancies are highly vascular, and angiogenesis is rampant in these structures, and even small manipulation will cause bleeding. Depending on the size of the tumor, the amount of hemorrhage may be very significant, and patients may present with chronic anemia secondary to this. So patient may be asymptomatic at the time of the onset of disease, but may have anemia as a sign of cancer. Anemia may be warranting for a very thorough examination, and unexplained anemia is always a red sign. You cannot say this patient is old, that's where they live, and their hemoglobin is 9, so they're fine. Again, old and young are relative terms. Anemia, meanwhile, or hemoglobin levels are not. So again, if your anemia, your hemoglobin levels are lower than your guidelines, your lab guidelines, so it definitely warrants you to for further evaluation. One of the common evaluation strategies will be to re-examine patient for renal disorders, which may be sign of aplastic anemia, but in this case, when a patient may have a cancerous growth, one of the common strategies is evaluation of the GI tract to look for tumors or malignant polyps that may present with slow bleeds and overall slow reduction of hemoglobin level. So at this case, in both cases, if it presents like anemia of chronic disease, the size of the cells and the color of the cells may be normal, but the amount of the cells abnormal. So anemia of chronic disease may be actually signifying the cancers, especially the cancers of GI tract. If cancer is invading bone structures, it's quite possible that patient will present with unexplained fractures, and which may be sign of metastasis and bone invasions, or in case of osteosarcoma, this definitely will be one of the signs of presence of the primary tumor. Infection secondary to suppressing of the immune system are quite common, and one of the key visual characteristics of the cancers will be cachexia when patient losing weight, and cachexia occurs secondary to increased metabolic demands of the body, and which is secondary to increased metabolic demands of the growing tumor uncontrolled. So your patients may have even sufficient caloric intake but still lose weight. At the same time, patient may present with loss of appetite, and in addition to loss of appetite, patient may have cachexia secondary to increased metabolic demands of the tumor. In this case, we can prescribe patients some pharmaceuticals that may contribute to increase of appetite, such as Megace. To complete this presentation, I would like to talk about cancer treatments very briefly, and there are different treatment modalities for cancer you can see in your patients. The treatments have numerous side effects, especially chemotherapy, radiation, as well as hormonal treatment, but don't forget that these are life-saving, last resort treatment. So some of your patients may focus on side effects and be resistant to receive the treatment because of that, but however, your job is to explain the benefits of the treatment as well as the side effects. What I'm talking about is the concept of informed consent. Means we don't give any treatment in any condition without patient or patient's family if patient is not able to make decision for treatment. So the treatment, surgical excision may be very successful modality of treatment if it's done early in the timeline of the progression of the disease. If the cancer is metastasized, surgery may take a palliative, and by palliative I don't mean the end-of-life role, but the palliative role which may reduce, let's say, compression on vital organs or reduce the size of the tumor. But at that time, surgery may be followed by chemotherapy and radiation. Chemotherapy is a systemic treatment, and in addition to attacking the primary tumor, it may also affect the metastasis. Again, the details of this will be in subsequent chapters and lectures, as well as in your pharmacotherapeutics course. Radiation is a local treatment, and radiation is local targeted treatment, which may be of the purpose to shrink the tumor, or it may even be a palliative treatment to prevent cancer from spreading. Radiation techniques improved vastly within last few decades. To give you an example, when we talked about Henrietta Lacks' case, in her case, the cervix was packed with radium, and it's not seeds, but it's like a packing with the gauze type of material, and the patient was sent home. Today's radiation treatments are highly targeted and focused, and that may affect only the tumor itself. But again, radiation has all the side effects, and one of the most visible ones will be the radiation burn you will see on the patient's skin, as well as it can affect and be actually carcinogenic for the staff in the hospital. And at that time, of course, strict radiation prevention, radiation exposure prevention techniques should be utilized, and staff should be protected. Hormones is one of the common modalities of treatment, and hormones can be used for breast and prostate cancer. As you know, most of the breast cancer are estrogen sensitive, and most prostate cancers are testosterone sensitive. So by increasing the amount of counter hormone, we may reduce the size of the tumor. When we're talking about prostate cancer usually is not an aggressive disease, but it can spread relatively slow. So at that time, some patients, and usually it's depending on patient age, comorbidities, may opt out for hormone treatment. At that time, patient given doses of estrogen, which keeps the tumor size under control or even may shrink the tumor. Most of the time, male patients will experience the side effects related to excess estrogen and may have gynecomastia, hair loss, and other related conditions such as thinning of the voice. But again, the decision is usually made after a thorough discussion with the patient about the modalities. Usually younger patients may opt out for more radical treatments such as surgical prostatectomy. In breast cancer cases, hormonal treatments can play palliative role, and treatment with testosterone is fairly common if it's a palliative care and it's something non-operable, but the tumor is not feasible to operate at that time. Giving testosterone may keep the initial tumor as well as the metastasis from growing or growing rapidly, which can buy some time and be a type of palliative treatment again. This concludes the cancer or neoplasms lecture. Please again contact me if you have any questions, and I will see you next time, and hope you will enjoy the next lecture.